Good evening, friends. Today we'll talk about the macrophage activation syndrome. This topic is nowadays is coming into the limelight because of the because of the COVID pandemic. And initially, this macrophage activation syndrome, people know very less about this. Now people are talking about because of this since the COVID has entered into the world. So, what is the other the synonyms? Most of the people know the cytokine storm syndrome or cytokine releasing syndrome or hyperinflammatory syndrome. These are all synonyms of the more or less similar to the macrophage activation syndrome. Under this umbrella, single, this a lot of other disease comes into the picture. Like this macrophage activation syndrome is otherwise known as HLH. Mostly it is a prime familial disease where the defect in the gene because of the cytotoxic lymphocyte or NK cell toxic killing effect. Then the secondary due to the autoimmune diseases like systemic onset GIA or SLE or other inflammatory autoimmune diseases. Then you can call it as a secondary HLH or macrophage activation syndrome. Apart from that, the sometimes infection like viral infection or bacterial infection, those can precipitate the macrophage activation syndrome. And lymphoma malignancy, that is otherwise known as malignancy associated macrophage activation syndrome or malignancy induced HLH. Now this is viral, except especially the COVID is more having more prone for developing the cytokine storm syndromes. So these are all more or less similar picture, and they have again similar clinical features. Sometimes is related to the ARDS. So what is macrophage activation syndrome? Mostly this macrophage activation syndrome as a rheumatologist or most it is known because of the rheumatic diseases that is most common in the associated with the rheumatic disease in the childhood, particularly systemic onset GIA. And when you call it is a like in familial as I already mentioned, like familial HLH or sometimes associated with the virus, leukemia or cancer, EBV virus. And they are characterized by uncontrolled activation and proliferation of T lymphocyte and macrophages. Because there is defect in the killing of the cytotoxic T lymphocytes or NK cells. That is why the macrophage is constantly getting activated because of non-elimination or persistence of the viral infection or any underlying infection that leads to the persistent activation of the macrophages. So that will lead to the different production of the cytokines that leads to the macrophage activation syndrome. And this shares clinical laboratory features, especially with the primary hemophagocytic lymphocytes, otherwise known as familial HLH. So it is now easy to overdiagnose if you think every case like it is developing macrophage activation syndrome, and also if you not think of like then easy to underdiagnose also. So there are some the gray areas when to detect this when to suspect that patient is going to develop macrophage activation syndromes. So what are there are different cells plays a role in your immune system. So especially there are three cells that is takes part in the macrophage activation syndromes are NK cells, cytotoxic cell and macrophages. So there are defects in these cells like NK cells and cytotoxic cell. That is why there are constant activation of the macrophages. So these are the three major cells takes part in the role of the main pathogenesis of the macrophage activation syndrome. So what are the pathogenesis of the macrophage syndrome? It is like gradual activation. Initially, those patients have genetic predisposition like TLR hyperresponse or subclinical genetic defect in the cytotoxicity NK or CD8 cell. When they got some disease like any autoimmune disease, let's say systemic onset GIA or SLE, they have underlying high levels of cytokines like IL-6. In the meantime, when they trigger with some viral infection like EBV, CMV, then they can precipitate to the macrophage activation syndrome. Mostly, they have increased production of the interleukin 1 and interleukin 18. Along with that, this viral infection cause persistent activation of the T cell, which leads to the interferon gamma production and macrophage activation. So all those leads to the macrophage activation syndrome. The trigger is important. Along with that, genetic predisposition and underlying diseases. So now there are, along with that, other diseases coming into the picture, like macrophage syndrome, mostly after the institution of the CAR T cell therapy, like OKT3. This OKT3 is more common culprit in the drug which are used in the lymphoma cases. So that is also mostly predisposed in the macrophage activation syndrome. So either sometimes it is a loss of function or in the gain of function. So both can cause this macrophage activation syndrome. As example, like especially with macrophage activation syndrome, it is because of the gain of function of the mostly innate immune boundary. Whereas perforinopathy with primary HLH, because of the loss of function, because of defect in the porphyrin enzyme, porphyrin pathway, or different synaptophysin. So there it leads to the loss of function of the immunity, that leads to the your primary or familial HLH. So sometimes it associates the loss of function of the immunity or gain of function. Then again they divided into the whether it is the innate immunity activity or the adaptive immunity activity. Innate immunity activity mostly because of the myeloid malignancy or dysplasia associated with the macrophage syndrome, and NLRC mutation related to the macrophage activation syndrome. Whereas adaptive immunity gain of function mostly associated with the T cell lymphoma or CAR cell mass or other T cell directed therapy or systemic onset JIA, mostly associated with the gain of function of the adaptive arm. Whereas your EBV associated lymphoma associated macrophage syndrome mostly because of the loss of function in the adaptive immunity that caused to the macrophage activation. So there are some overlying pathology, like as you know, this porphyrinopathy or SOGI associated systemic onset GI or adult still disease associated mass. They can have both gain of function and loss of function. So there are some gray areas which can lead to the mainly macrophage activation syndromes. What is the primary mechanism of the primary HLH or macrophage activation syndrome? As I told, like there are these are effector cell, NK cells, and these are the target cell. If there is any defect in the pathway of killing of the target cell by the NK cell, then that will lead to the persistence infection inside the target cell or antigen presenting cell. So that is why either in the defect in the porphyrin or in the any genes that leads to the production of the vesicles, formation of the vesicles like snare protein, MONC, syntaxin, mTOR, RAB. These are all common genes that leads to the mainly primary HLH or macrophage activation syndrome. So as I told you, these are the primary genes like porphyrin, ONC, syntaxin, LIST, RAB27. Like these are mainly related to the vesicle docking or pore forming proteins. So whenever there is defect in these genes, that is mostly associated with the familial history is very much important. They develop mostly macrophage activation syndrome in the early age of the life. I told you this trigger either in infectious or underlying malignant or rheumatological or metabolic condition, that defect, genetic defect, either subclinical genetic defect or in the presence of that, it can lead to the uncontrolled proliferation of the lymphocyte, which leads to the production of the interferon gamma. This interferon gamma which cause more of activation of the macrophage, and these macrophage products produce them different cytokines such as interleukin 1, TNF alpha, interleukin 6. Those are the main cytokines which cause the clinical different presentation of the hemophagocytic lymphocytosis. What are the different pictures will come across in a patient when you see different types of macrophage activation syndrome? So this COVID mostly confined with the pneumonitis, pulmonary ARDS-like picture, hypoxemia, and immunothrombosis. Immunothrombosis in a setting of the COVID. Then liver, when it affects the liver, hepatomegaly, it causes transaminitis, hypoalbuminemia, because they can cause the diffuse anasarca. Kidney can also, they can affect the kidney like acute renal dysfunction, renal failure, and different cytopenias, like start from the pancytopenia to the anemia to the leukopenia, sometimes associated the leukocytosis also. And whenever there is progression of this macrophage activation syndrome, it can cause the DIC like pictures and coagulative bleeding, capillary leak syndrome, vasodilated shock, and spontaneous hemorrhage. And it also involves the nervous system and cause the seizures, delirium, altered sensorium, and fever, anorexia is a primary constitutive symptoms. Heart, it can cause the myocarditis. That is why you can see the most elevated of the pro-BNP level, and hypotension. and associated with underlying rheumatological conditions like arthritis, vasculitis, ulcer, skin ulcer, that you can get in the setting of the macrophage activation syndrome. And GI system also, it can involve the cause diarrhea, nausea, vomiting, and ascites, and skin, and it can cause the rash or ulcer. So it can affect any organ of the body, like always in the setting of the macrophage syndrome, you have to keep like all the organs it can get affected. So why it is having like these are underlying symptoms? Because of the different pathogenesis underlying mechanism, because of the interleukin 1, TNF alpha, interleukin 6. I told you, because of the constant activation of the macrophage by the interferon gamma, it can cause the fever. So why there is cytopenia? Because of the suppressive activity of the TNF alpha, interferon gamma, and heavy unit of ferritin and hematopoiesis and hemophagocytosis. This hemophagocytosis, this macrophage will engulf the your precursor cells like your normoblast, erythroblast. Those cells can be engulfed by the macrophage. That it leads to the cytopenia. And apart from that, there is suppressive activity of the TNF alpha and interferon gamma on the bone marrow. And why there is hypertriglyceridemia? Because of TNF alpha inhibits the lipoprotein lipase. And why there is hypofibrinogen? Because the high levels of plasminogen activator secreted by the macrophage stimulate the plasmin, and in consequence lead to the hyperfibrinolysis. That leads to the low fibrinogen in the blood, and high concentration of ferritin because of the release by the activated histocyte or macrophages. And you can get sometimes the interleukin, when you do the interleukin 2 receptor, soluble 2 receptor, there is high, you will get the high levels of in the blood because of constant activation by the T lymphocyte. And hepatosplenomegaly, increased ALT, AST because of the organ infiltration of the lymphocyte or histocyte or macrophages. So these are the clinical features and underlying mechanism why you are getting all the organs are involved, and all the clinical features because of the different cytokines and activation of the macrophage or lymphocytes. The normal immune response, why it occurs macrophage activation syndrome, how it differs from the COVID-induced cytokine storm. So normal, whenever there is viral infection occurs, the CD8 cells or cytotoxic lymphocytes will activate, and they will kill the antigen presenting cell which has virus inside it. If that cytolytic elimination of the cytotoxic lymphocyte and antigen presenting cells occurs, then there will be gradual resolution of the inflammation took place. If anywhere in the defect, either in the cytotoxic lymphocytes or activation of the macrophages or defect in the NK cells, then that can lead to the persistent viral infection inside the body. The normal immune response is like normal cytotoxic activity. It can remove the timely manner in remove the viral infected cells. What happens in the macrophage activation syndrome? There is already the patient is having any autoimmune diseases such as systemic JIA or your SLE. Most commonly, as they are associated with the macrophage activation syndrome, there are defects in the cytotoxic T lymphocyte. That is why whenever there is any infection, there is constant expansion of the cytotoxic lymphocyte because they are inability to kill the antigen presenting cell. So that inadequate elimination of cytotoxic lymphocyte and persistent innate immune activation leads to the more production of interferon gamma, and which leads to the activation of the macrophage. That in return produce the interleukin 1, interleukin 6, and again it can activate the your adaptive arm. So that can lead to, it is a vicious cycle. It goes to the cytokine storm. And what happens in the COVID? Like there are activated SARS-CoV infected macrophages and dampen type 1 interferon response. It has been shown that in early, those patients have COVID cytokine storm severely, they have dampened type 1 interferon response that allow persistent cellular infection and cytolytic exhaustion, and sometimes it also leads to the complement activation. So unlike, what are the typical features? Unlike in macrophage activation syndrome, the cytokine storm set is associated with the predominant endothelial dysfunction. Because of this production of cytokine that can cause this predominant endothelial dysfunction, that is why more you are getting immunothrombosis and diffuse fluid retention or hemoglobin concentration leads to the progressive organ damage. This in macrophage activation syndrome, you will get in severe part of macrophage, you will get the bleeding manifestation, whereas in COVID-induced cytokine storm, mostly you will get the endothelial dysfunction that leads to the immunothrombosis. So what are the triggers? Apart from the common virus I already mentioned, like EBV, others are cytomegalovirus, HIV, hepatitis A, B, staphylococcus, other bacterial, staphylococcus, streptococcus. Why this staphylococcus, streptococcus? Because they have some antigen that is known as super antigen. So these super antigens, they have simultaneously activated the T cell and MHC cell. That is why they have not specifically targeted to the any MSC. So because they are having mostly super antigen, so they are more prone for developing the macrophage activation syndrome, and sometimes associated with the microbial tuberculosis, leishmania, and apart from underlying malignancy like EBV, associated malignancy, lymphoma, non-Hodgkin's lymphoma, hepatocellular carcinoma. So there are different triggers which can lead to the development of the macrophage activation syndromes. So most important clinical feature I told you, it is non-remitting fevers. This systemic onset JIA, mostly they have intermittent fever. When the child is developing like continuous fever in a case of systemic onset JIA, then you can suspect the child is going to develop macrophage activation syndrome. And hepatosplenomegaly, lymphadenopathy, because of proliferation of the lymphocytes, they have that is why more of reticular endothelial system hyperplasia, and hemorrhagic manifestation because of the thrombocytopenia. Why there is thrombocytopenia? Because of the like bone marrow suppression or hemophagocytosis, that can both can lead to the thrombocytopenia. Encephalopathy, less common, hepatitis, myocarditis, seizure. But in COVID-induced macrophage activation syndrome or COVID-induced cytokine storm, you can get like long predominant organ specific features like ARDS in the case of COVID-induced macrophage activation syndrome. And these are the laboratory features you will get: cytopenias, pancytopenia or thrombocytopenia or anemia. Transaminitis is an important feature of macrophage activation syndrome. Coagulopathy, decreased erythrocyte sedimentation rate because of the hypofibrinogenemia. Hypertriglyceridemia, increased LDH. Hyponatremia, again, is a prognostic feature. Hypoalbuminemia, hyperferritinemia, increased soluble CD25 and increased soluble CD163. This increased soluble CD125 is IL-2 receptors that are marker of the T cell activation, and CD163 is a marker of the macrophage activation. So there are constant activation of the T cell and macrophage. These are the important laboratory features you come across in the case of macrophage activation syndrome. Secondary HLH mostly due to the rheumatic disease or infection and malignancy, and various diagnosis classification criteria are there how to diagnose a case of macrophage activation syndrome. Most important is like HLH 2004, mostly for the familial hemophagocytic lymphohistiocytosis. For that, you need a molecular diagnosis concerned with HLH, and diagnostic criteria HLH was 5 out of the 8 criteria, like hepatosplenomegaly, cytopenia, hypotriglyceridemia, and hypofibrinogenemia. Hemophagocytosis in the bone marrow or spleen or lymph node, or no evidence of the malignancy. Or new diagnostic criteria, low or absent NK cell activity, also you can prove that, and ferritin more than 500 and soluble CD25 is a marker of the T cell activation. So there are HLH criteria. And for the systemic onset JIA, the 2016 ACR proposed a criteria for the macrophage activation syndrome in the case of systemic onset JIA if there are persistent continuous fever and ferritin more than 684 and any of the two of the following, like platelet less than 1.8 lakh, SGOT is more than 48, triglyceridemia more than 56, and hypofemin less than 360. So if any of the two of the following with hyperferritinemia, then you can classify as a having child of developing systemic onset JIA. Again, there are criteria for the juvenile lupus also. And here this slide shows and COVID-induced hyperinflammation, like COVID-induced hyperinflammation syndrome, COVID-induced hyperinflammation, and temple criteria. They propose a criteria for the COVID-induced hyperinflammation. And one important score here I want to tell you, like H score. H score, they taken several parameters like fever, hyperferritinemia, organomegaly, cytopenia, triglyceride, hypofibrinogenemia, elevated AST, LDH, immunosuppression, hemophagocytosis, NCAS, and then total diagnosis, some parameter 1 of 69, then that patient is going to develop, most likely they're going to develop the macrophage activation syndrome. And this already I mentioned in the 2016 mass criteria in the system GIA, and this is COVID-induced hyperinflammatory syndrome. Another is COVID hyperinflammation, like ferritin more than 1500 or CRP more than 15 or doubling. So they are mostly, there are two parameters which can tell you that the patient is going to develop this COVID, underlying COVID, they're going to develop hyperinflammatory syndrome. Another that temple criteria. There are several criteria which can tell you, like when the patient is going to develop the COVID-induced hyperinflammatory syndrome. Apart from that, macrophage activation syndrome, there are HLH criteria and H score, and 2016 mass criteria for the systemic onset GIA. Now, what are the caveat in diagnosis? Classification criteria is not always a diagnosis, because it is not a diagnostic criteria. So if you want to wait till all the criteria fulfill, then you will lose the golden opportunity. And always clinical bedside picture is more important rather than the classification criteria. And remember, in a case of like normal TLC count in a sick patient of systemic and JIA is abnormal, means the systemic onset JIA, they have mostly they have leukocytosis. Now a systemic onset JIA child coming with the continuous fever with TLC count of 5000, then you can suspect the child is going to develop macrophage syndrome, because there are disproportionate TLC count, disproportionate low TLC count in a case of sick child, in a case of systemic GIA, then you can raise the suspicion of more of like child is going to develop the macrophage activation syndrome. So clinical suspicion is much more important, not that always the classification criteria. So what are the important signs, red flag? Don't miss the macrophage. Altered mentation, drowsy, altered fever patterns, like I told you, continuous fever is a feature, continuous and ill-looking child, like you can think of macrophage activation syndrome. And unexplained hyponatremia and sick throughout the day. And sick throughout the day, if the patient is having macrophage activation syndrome, they will be sick throughout the day. And you can guess from this, looking at the mentation of the patient and looking at the behavior of the patient, they can have all the organ involvement, like starting from the hepatopathy, bleeding diastasis, fever, drowsy, they can have myocarditis, hypotension, renal failure, they can have ARDS. So think about the clues, that is more important. And may not be mass, no clinical feature except fever. Only the patient is having fever, but the laboratory features normal CRP level. If all the macrophage activation syndrome patients, mostly invariably they have elevated CRP levels. Only fever, don't think of like only macrophage activation syndrome. And TLC platelet more than upper range of limit. I told you, like in macrophage activation syndrome, they will have cytopenias like leukopenia and thrombocytopenia, and ESR high. So ESR high, again, because of hypophosphatemia, ESR will be low in the case of macrophage activation syndrome. So serial monitoring ESR is more important and easy to do. So ESR high, even if it's persistently continuous, get increasing in trend, so it may not be a case of macrophage activation syndrome. And because invariably they also cause the transaminitis. So if the patient is having normal liver function test, so also some chances of macrophage activation syndrome are also less. So the normal CRP level, normal TLC or platelet count, ESR is high, normal AST-ALT may not be a case of macrophage activation syndrome. So these are macrophages, like engulfing your precursor cells, hematopoietic precursor cells, that can cause the cytopenias. But it is not that always you will get this hemophagocytosis in the case of macrophage syndrome. And around 60 to 70% of the cases of the bone marrow biopsy or lymph node or spleen, and then you can get the hemophagocytosis. So always it's not that you can get the hemophagocytosis in the macrophage syndrome. The clinical picture is much more important rather than the bone marrow biopsy. And here, so what are the in India data? Like there are 80 cases of hemophagocytosis. There are what are the precipitating factors, like infection and leukemia, Hodgkin's lymphoma, nutrition, anemia, multiple myeloma. These are underlying causes of leading to the hemophagocytosis syndrome. Apart from that, marked hyperferritinemia does not predict for macrophagocytosis in adult population. One study in the 2014, like out of 113 patients with ferritin levels higher than the 50,000, but out of that, only 17% ultimately developed diagnosed with the HLH. So always like hyperferritinemia is not going to the develop the patient with HLH. Clinical picture is much more important apart from that laboratory pictures. So what are the treatment available? So depending upon the cause of the macrophage activation syndrome, there are different proposed line of therapy. So if the patient is having primary HLH, the HLH 94 protocol, dexamethasone, etoposide, or bone marrow transplant is the ultimate treatment. Or secondary infection, with the infection associated like tuberculosis, you have to treat with the ATT, not with the steroid. And EBV, HIV, you have to give your specific therapy. CMB associated mass, you have to give the gencyclovir. Rheumatological underlying conditions, you need to treat it aggressively. Kawasaki, IVIG, malignancy like CHOP and Rituximab. These are the primary underlying treatment of the disease is much more important. So specifically treatment of the primary HLH or secondary HLH due to the autoimmune conditions, high dose steroid is the primary line of treatment. If it not respond, patient develops fever, then you can go with the cyclosporin A. And after that also, if the patient have CNS involvement or constant fever, then you can go with the other line of therapy like HLH protocol, etoposide. And there are other biological treatments also available. So how much dose corticosteroid should be indicated in the macrophage syndrome because of the autoimmune conditions like Paul's methylprednisolone to give for 3 days. A more 50% rate response is due to the steroid. If not respond, then you can go with the cyclosporin, either continuous IV infusion or tablet form if the patient is sensorium is maintaining. Then HLH protocol, initial therapy is dexamethasone. If not respond, then you can go with the cyclosporin or etoposide therapy. There are different targeted therapy depend upon the defect in the pathways. Like if there is more of cytotoxic T cell, then you can inhibit the interleukin 2 by the cyclosporin or tacrolimus, or you can give the etoposide. When there is more of production of the interferon gamma that leads to the macrophage, then you can block the interferon gamma, or you can block the JAK inhibitor like tofacitinib or baricitinib. Or when there is a activated of macrophages constant which produce the different cytokines, here also you can block the interleukin 1, that is anakinra, interleukin 6 tocilizumab. So all this are targeted therapy. You can inhibit any step that depend upon the defect in the pathways. IVIG is a conflicting result, but it has mostly helped in the infections related to the macrophage activation syndrome. So whenever there is high procalcitonin or any blood culture is showing any infection, then you can go with the IVIG. And rituximab sometimes associated with the you can consider in the EBV associated mass, because this EBV is mainly harbored by the B cells which express the CD20. So rituximab mainly eliminate the cells harboring the virus, because unless you are not removing the virus infected cells, there will be constant activation of the macrophages. So treatment according to the cause. So mostly CART therapy, I told you, OKT3 therapy, there interleukin 6 is the or glucocorticoid, or pathogenic bacterial sepsis, it is the intravenous antibiotic. EBV, B cell depleting therapy or glucocorticoid. COVID-19, mostly glucocorticoid, sometimes tocilizumab. And primary HLH, either you can give the etoposide, cyclosporin, tacrolimus, or T cell inhibitor therapy. So I'm going to go for the bone marrow transplant. Secondary, I mentioned either T cell inhibitor, glucocorticoid, JAK inhibitor, and autoinflammatories like anti-TNF or anti-interleukin 1. So final, why the macrophage activation syndrome? Because of the either iatrogenic cause like any drug therapy, or any underlying monogenic defect or autoimmune conditions lead to the any triggers by the any pathogens, induced triggers like bacterial sepsis, EBV, or COVID-19, that can lead to the more of activation of the adapter cells or innate presenting cells, and leads to the more of immune hyperactivation. And whenever there is defective in the production of anti-inflammatory cytokines or Treg cells, that will lead to the immune more of pro-inflammatory cytokines, that leads to the more of interleukin 18 and TNF, interleukin beta and TNF alpha, and that leads to the more of acute systemic inflammatory effect, fever, multi-organ dysfunction. And at any time, any point of time, you can target all these of cytokines, but the clinical suspicion and timely action of this targeted therapy is much more important. Once there is passes of the times, then there is more of that organ damage occurs, then there is chances of recovery also less in macrophage activation syndromes. So clinical judgment is much more important. No isolated investigation will help. Like ferritin, I told you, hyperferritin not always will tell you like macrophage bone marrow biopsy. Only 60% of cases they can have your macrophage syndrome, or various criteria like H score or COVID-induced temple criteria. Only specificity mostly 75%, and treatment must address the underlying cause. Remember, the infection-associated mass, you have to give the treatment underlying the cause, either antiviral or antibiotic or anti-tubercular according to the underlying cause. Thank you.